All right, so our next session 2, it's going to be geriatric pelvis and acetabulum, optimal management strategies. I mean, I think we all, if you're taking call in the hospital or rounding on patients, you see these patients, they come in, when do you need to do something for them? I think we're going to get to see some good cases. So we have Nick Quercetti, Matt Craig, Matt Garner, Dan Horwitz, Joel Williams, and I'm going to turn it over. So I'm going to stop sharing here and I'm going to let Dr. Quercetti share his screen if he's able to do that. And if there's any technical problem, let me know. I do have your slides.
All righty. How's everybody doing? All right.
Looks good.
Sakib, you can see that?
Yeah, I can see that pretty well. I can hear you.
All right, great.
Thanks.
So I'm Nick Quercetti. I'm out of Newark, Delaware. I do orthopedic trauma surgery. We're going to be talking about geriatric pelvis and acetabulum fractures today. So these are our panelists. We all just got introduced. Everybody specializes in orthopedic trauma surgery. The learning objectives today, everybody needs to understand low energy fractures are not the same animal as high energy fractures. Very different as far as patient outcomes, expectations, biology, the kind of fracture you're treating, bone quality, classification, and management strategies. CT scan all lower or low energy pelvic fractures. I can't stress that enough. I can't tell you how many times I see a elderly pelvic fracture that comes in my office, seen at an ER elsewhere. They were told they had no injury, and then they come in and they can barely walk. Individualized treatment plans, and then always remember patient biology. So we're not just treating the bone with stability and trying to get it to heal, but we also have to help these people heal with their biology because it's not optimal when they come to us with these injuries. First and foremost is you need to identify who your patient is. We're not treating the 16-year-old that was in a car accident. This is your patient when you walk into the hospital room or the ER and you see them, and you need to figure out, is it this lady who sits in a wheelchair in a nursing home all day? Or is it this lady who likes to walk 2-3 miles every day around her community with or without assistance? So what are we trying to get this lady back to? So the challenge that we're all going to be faced with is currently, these are the risk percentages for women and men in the 65 to 90 year range. 6.9% of all women are at risk for pelvic fracture and 2.8% of all men. Over the next 20 years, it's going to triple. So we're going to be seeing a lot of these injuries in the next 2 decades. And I'm already seeing a fair amount here at my hospital surrounded by nursing homes. So these are not the same as your high energy injury. You have a different patient. This patient falls frequently. They have comorbidities. They may be on blood thinners. They have dementia. They may not be able to follow your instructions, and they have dramatically different expectations than a high energy younger patient. Their biology is different. They're malnourished. They don't have quite the healing potential. And they have multiple comorbidities often. And most of all, the bone is dramatically different. This is not really strong bone. The ligaments are stronger than the bone half the time. And this is not a violent explosion of bone from a high energy injury. This is a fall from a standing height or, the second step. And this is more of a crush and crumple injury. This is not what we're talking about today. We're talking about crush and crumple from not a lot of energy. You get minimally displaced fractures a lot of times. Sometimes you can't even appreciate the displacement until you push on it. Unfortunately, for geriatric pelvis and acetabulum fractures, there are currently no agreed upon algorithms. For fragility fractures of the pelvis, there has been a very thoughtful classification proposed by Paul Ramans out in Germany. And as far as the acetabulum goes, there's a very good treatment algorithm proposed by Evan Carroll from Wake Forest in 2010, and we'll review those briefly. This is Paul Ramans' proposed classification from 2013. So you have, your type 1, which is just fractures in the front, nothing in the back. These are relatively stable. They don't need anything. Then you have class 2 fractures, A, B, and C. They're incomplete until you get to C. C is where you start to have that non-displaced, complete sacral fracture that can eventually progress. So this is where fragility fractures of the pelvis are very different from high energy younger patients. What you see on the initial imaging is not what you're going to end up with 6 weeks to 2 months down the road. You can have a progression of injury from what you think is one type of severity to 6 weeks later. Now they have another type of severity. These can displace, and you can have more of your type 3 fracture where you have a displaced complete posterior injury, either in the ilium, the sacrum, or your SI joint. And then the fourth type are bilateral. And these are where you can get into pretty dangerous pelvic fractures, especially with the type B, where you have what I like to call your elderly spinopelvic dissociation injury, where you have a zone 2 fracture bilaterally, and then they connect usually through S2. On initial exam, initial x-rays, not that impressive. 2 months later, you're going to start to have a flexion deformity on a sagittal image on the CT scan. And this is why it's imperative to get a CT of all of these elderly pelvic fractures. You have to get that CT to evaluate that sagittal cut, see if they already have that flexion deformity, make sure that it is a unilateral injury, probably what the x-ray showed, make sure it's not bilateral, make sure it's not worse than it is. There's been a lot of work to show that a significant amount of posterior pelvic injuries can be missed on the initial AP. So make sure you get that CT scan. As far as elderly acetabular fractures go, like I said, Carroll in 2010 proposed a very, very good algorithm for acetabular fractures. And the biggest questions are, can they or can they not go to the operating room? Is this patient safe? And then if they are safe to go to the operating room, what are we going to try to accomplish? Can this patient tolerate up to 3 to 4 hours of an ORIF? Can you do everything through a non-extensile single approach? And is the cup salvageable? Are you going to be able to reconstruct that acetabulum, allow them to put some weight on it? Or is the dome completely crushed, not salvageable? They should get a total head. So these are all the things you really have to think of. And blood loss. You can have up to average blood loss is reported to be 1,100, 1,300, 1,400, depending on what study you read. But these are the big questions that I ask myself. And then you have to be very realistic. I think a lot of us think we can fix everything. We want to make everything look anatomic, but you have to be realistic. Is the dome crushed? Probably not going to salvage it. They should probably get a total. So, our first case is this 84-year-old male fell from a standing height. These are his medical conditions listed. Relatively active, lives at home with his grandson, walks with a cane, single story, he still drives, and he's completely mentally competent. So on first glance, again, this looks like nothing, just looks like non-displaced superior and inferior pubic rami fractures. When you get the CT, you look at the sacrum, you notice you have a complete sacral fracture. It goes all the way through. This is more of that type 2C injury where it can potentially progress, and they can get a progressive internal rotation deformity. So talk to the patient and the family. They really wanted to have surgery after they had failed non-operative management. So the patient was from out of state. At initial presentation, didn't want to have anything done, said, sure, great, we'll do physical therapy. After about 4 days, you realize he couldn't get up and stand on it. Now, after day 4, they want surgery. So we go to the operating room, and this is, I've started getting lateral compression stress images of all these just to demonstrate the amount of internal rotation that will occur with weight bearing. And this was this patient. So you get 1 centimeter of displacement. Saji described the manipulation under anesthesia for younger higher energy traumas, but I still do it for elderly patients as well. Percutaneous fixation. This was a little while ago. I've now gone using fully threaded screws because they get better purchase. But screw in the front and then put 2 screws in the back, transiliac, transsacral. And then he felt great. Pain typically goes from about an 8 to a 9 pre-op down to about a 3 immediate post-op. And a lot of these people are able to get to home rather than the rehab. So, you know, my panelist, Dr. Horwitz, would you have taken this patient to the operating room, or would you have treated him non-operatively? What's your protocol?
You're muted.
Yeah, sorry. It said the host wouldn't allow me to unmute. I probably wouldn't have fixed this. I think that, yeah, I think you mobilized him faster, and I think he went home. I would have. My goal is not to have him necessarily be walking. Certainly not weight bearing on this. My goal is for him to be able to get bed to chair, bed to the toilet with a walker. I don't think his X-ray would look any different at 3 or 4 weeks, and I think at 3 or 4 weeks, his symptoms at that point would abate. If he couldn't get out of bed to a chair, then I'd consider it. I've never seen this injury not be able to get out of bed to chair, as opposed to a U-type. So I don't think I would have fixed this.
Yeah, I think most people probably tend to agree with you as well. Dr. Craig, how about you? You think this was a little too aggressive?
No, I like what you did in terms of you treat the patient, not the x-rays. You get them up, you mobilize them, you attempt non-operative treatment. A couple days, if he can't mobilize, he's telling us that he's symptomatically unstable. I'm always curious about the EUA that people do. It wouldn't change my management. I've already decided to go to the operating room because the patient is symptomatic. I'm going to treat the patient. If you EUA enough things and you push on enough things, you're going to make everything move and you're going to operate on everything. So I'd rather have more of a clinical exam. How's the patient doing with their mobilization? Then make the decision for surgery. And then do something very similar you did here, stabilize the back, plus or minus the front, depending on the location of the fracture.
Could he not mobilize, or could he not weight bear on it?
He was able to stand and get out of bed, but that was literally it. He wasn't really able to take steps. The first day he got, 5 steps, and then he kind of progressively declined from there to the point that he was grossly uncomfortable moving about the bed and could barely stand. And that's pretty much kind of what I do is I try to give everybody a couple days of physical therapy if they have those very non-displaced fractures. So, and he failed, and he was really with it, and the family was very involved, and there was a lot of family members, and they all kind of wanted to proceed. Dr. Williams, what are your thoughts on this?
I like what you did. I think I would have done the same thing. When patients have an injury like that, or they have the initial injury filmed as you showed, and they can mobilize, I let them mobilize. I think there's a good study out of Loyola saying elderly low energy pelvic ring fractures probably don't even need a CT scan if they're mobilizing. And I'm more of that philosophy up front.
Yeah, if they're mobilizing, I think that's crucial.
Correct. When they can't mobilize, that's when it's a conversation with the patient, the family. What are your baseline functional goals? What do you do? Are you normally out of bed? And is this a significant change from your functional status? And if so, regardless, almost regardless of how minor the imaging appears, I think there's a role for surgery or discussing surgery with a patient like that, as you showed in this example. And then the other interesting thing I find about this topic is your stress exam was positive, probably. I mean, what does that mean? And how much displacement can you tolerate before you call it positive? If it's a millimeter, I think everybody would say negative. 2 centimeters positive. But if the guy healed with the displacement you showed on the stress exam, I don't think he would have had a functional deficit just from the mechanical malalignment. So these are all patients that I treat based on their ability to mobilize. And I think it's going to hurt, and you got to tell them that. But if they're able to walk, I steer them towards non-op. And if they're truly bedbound or they're really struggling to get out of bed, then push for surgery.
Yeah, I agree. I think it's all, the most important thing is what is the patient able to do, and what are their expectations, and what are their goals? I've looked at the past like 3 or 4 years of these cases just for myself, and it's about 33% of them that have been unable to mobilize and ended up wanting fixation. Dr. Garner, do you have a protocol when you see these people? Do you give them a certain number of days of PT when they're in the hospital? How do you proceed?
Yeah, I probably should. I can't say that I do. I think, a lot of the discussion goes back to what they were talking about in the last session with proximal humerus. What are the patient's needs and how can they tolerate surgery? I think, one of the questions that just came up in the chat was, do you get post-mobilization x-rays in this population? I personally don't care if they displace. I agree with all the comments before. It really, really matters how much pain they're having. But I don't have a good answer for what constitutes mobilization. I think it's different for everybody. So I make the same decisions based on how well they're doing and how well they're mobilizing. But I think the word mobilization is probably different for each patient, and it's probably more up to them than it is up to me.
Yeah, I think that's one thing we have to kind of firm down over the next, hopefully a couple of years here as a community is how much PT do we allow them to do? How much mobilization do we say you can do before we say you're going to be fine non-op versus, we should put screws in you now, as opposed to, maybe a month from now, you'll be feeling a lot better. So moving on.
Yeah, Nick, with that point, I think having hip fractures, everyone has to be weight bearers tolerated. You got to get them up, mobilize them, weight bearers tolerated. And non-operative treatment is not no treatment. So they have to have standing Tylenol, pair on oxycodone, and you got to get their pain under control. If you can manage them medically and non-operatively, great. That's fine. I have no problem with that. But if all of that is failing, telling them to wait a month or 6 weeks, I think is a little punitive. I'd rather stabilize and out the door, weight bearers tolerated.
Yeah, I agree 100%. I try to prevent these people from suffering all of the collateral damage of immobility. We rush hip fractures to the operating room. That's a great point. And that's kind of how I've started to think about these is if they're not up in a day or two and they're in a lot of pain, then it's like, we got to get you mobilized. Our second patient is a 66-year-old male, fell 3 feet from the ladder. He's an auto mechanic. He's very active, a little bit of pre-existing lumbar spine disease. My facility, when they come in as a trauma, I think trauma forgot that we have x-rays and everybody just gets CT scanned, even when the orthopedist orders x-rays. So this is just a scout film of this patient. Pretty much everything's non-displaced. But when you get the CT scan, you can see on the right side, he has a zone 3 sacrum fracture. That it's a zone 2 on the right side, but it 100% crosses at S2, and it's a zone 3 fracture. And he's already starting to get, you can see on the sagittal cut there in the bottom right that this is likely going to become a flexion deformity. But as pointed out, is the flexion deformity going to be tolerated or not? So I talked to the family. Patient wanted to have surgery. He was really active. And I've had a couple of these where you put in transiliac transsacral screws and the patient still has some low lumbar spine pain, some sacral pain. So in this patient, I got my spine partner involved and we put in some posterior spinal pelvic fixation as well. And I put a screw in front because he did have a slightly displaced anterior column fracture on the right there. You can see on the top right image. And this guy was up and walking day one, felt great. And he's since followed up and he's done very well. But this, I thought maybe was a little aggressive, but the guy was going to push the envelope and really get after it, and I didn't want him to have any issues. What are your thoughts on this, Dr. Garner?
So, my indications for lumbopelvic fixation or spinal pelvic fixation are continuously evolving. I don't know that I have as much, maybe I don't have as much experience with the kind of failure rates or concerns for progressive kyphotic deformity. I can't say with fairly clean sacral fracture lines and what's kind of a borderline high energy, low energy injury. I think I probably would have treated this differently with percutaneous posterior and likely anterior fixation. I do think the pattern is far more unstable than it appears on his initial imaging, right? So whether it's some type of a lambda or there's a transverse component to this, which I think is really important. And you can't necessarily tell from the imaging, but if the 5-1 facets are involved, I'd be more likely to progress towards spinal pelvic fixation. But I think my first step would be to try to get compression across the sacrum and get some kind of inherent osseous stability, protect the back with a screw in the front, depending on what the actual pattern looked like. But I also recognize that the indications for spinal pelvic fixation are expanding, the complication rates are getting lower. So, in that situation, it may have been the right thing. I guess the question I would have is, did you need contralateral fixation? This appears to be a bilateral injury, but far more on the right than the left. So did you need to instrument the left side? And then the second question there, which is for my own information, is do you do a primary fusion? It looks like you did, or do you do, kind of the Saji triangular osteosynthesis with removal of implants later?
Yeah, so those are great points. That's why I picked this case. This is one where, I thought we may have, we threw the kitchen sink at this guy. He had some low lumbar spine degenerative disc disease to begin with, and some mild low back pain to begin with. But it wasn't really limiting for him. The guy was still an auto mechanic. I was pretty happy with my decision to go with the percutaneous pelvic fixation. And, where I kind of struggle with this is that enough? Was that enough? Did we have to bring him back to do this, the posterior spinal pelvic fixation? I was thinking we could stick unilateral on this one, just to the right side. But, my spine partner had talked to the patient and the family and decided to proceed with the lumbar fusion because of his pre-existing arthritis. Dr. Williams, you think this was a little too aggressive? Think it was appropriate?
Overall, agree with what Dr. Garner just said. I think the surgical indication is there. I mean, whether or not you stressed him or not, I'm plus minus on that one. I think it's much more relevant in the first case, but I do think fixation is warranted, and the 5-1 facets, I think, are part of my thought process in deciding how I'm going to fix the posterior pelvic ring. And then studying the 2D CT sequences to decide if I can get two good points of fixation percutaneously. So if I can get, it looks like probably the S1 or the upper sacral segment would tolerate 2 transiliac transacral screws, then maybe would have avoided spinal pelvic. But if I couldn't get 2, then probably would have called my spine colleague. And around here, we get all 4 of those options that you just mentioned, Matt. Sometimes unilateral, sometimes bilateral, sometimes it's a fusion, sometimes it's fixation in situ. It just sort of depends on who the spine surgeon is that's helping me with the case that day.
Yeah, I agree. We can get to run the gamut when it comes to posterior spine fixation. This guy he just had transverse process fractures. His facets were okay. So I think he might have been okay with just like an L5 to S1 on the right side only. But like you said, you asked 5 spine guys, you're going to get 5 different answers. Yeah. And what would your weight bearing protocols for this guy be, Dr. Williams? Would you let him fly? Would you give him any restrictions?
With the spinal pelvic, let him fly.
Yeah.
With this injury, and if I had without the spinal pelvic and I was able to get 2 good transiliac transacral screws and fix the anterior ring as you did, I would let him fly on the left side and ask him to limit himself on the right side. Probably start with 30 pounds weight bearing, but pretty quickly and aggressively ramp that up to weight bearing is tolerated.
Yeah, I agree. All right, so keep this moving. So this is just a paper kind of on a patient very much like this from 2018, where you had 114 low energy pelvic fractures, 16 of them, so 14% of them got fixed, and they were all this zone 3 sacral pattern that we had just shown. And the 16 that got fixed, 10 of them were fixed in delayed fashion at an average of nearly 3 months. And this is kind of almost what I see in the community as well. And the questions you have to ask is, are they able to mobilize initially? But a lot of them get that progressive kyphosis, worsening pelvic pain, decreased mobilization. And they all ended up wanting surgery. So here we have an 84-year-old male.
I'll interrupt. The mobilization in these is actually really impressive. I think that this is a totally black and white thing. Either they can get out of bed and walk with a walker and a 4-point gait, or they can't. And the amazing thing to me is the people that have basically these really minimally to non-displaced fractures in this age group, even just one transiliac screw, and in the recovery room, they will tell you, my God, I feel so much better. So I think it's really easy to underestimate in some patients the instability. The problem is I can't look at a CT scan and tell you who that is. The only way I can tell it is, can they get out of bed?
Yeah. The PT trial is critical, I think, day one. And how much can they tolerate, even if you do get a centimeter of play, like I showed on that first example. Some people can tolerate that and they get out of the hospital and you don't even know because you don't stress them. But the ones that come to the hospital, I feel, are the ones that have a lot of problems. They don't want to walk this off. And if they're unable to get up and mobilize, then it's like I really start to talk to them about bringing it back.
And I think that's something that a lot of people out in the community that don't necessarily do the surgery can actually apply. This patient comes in, you don't need to transfer them right away necessarily. I mean, you could do a PT trial, and then if they can't mobilize, then transfer them to one of you guys. But I see a lot of these sent in from an hour and a half away, and we get them out of bed the next day, and then the expense of all the transport.
Yeah.
And to that point, I've seen the opposite too, where somebody just assumes that they're going to do fine. They get discharged to a rehab facility, and then 5 weeks later, they end up being referred and they haven't mobilized. So
I agree.
We got to get the whole community to kind of understand these a little better. I see the same thing. We get them transferred and they don't need anything. And then I had a patient come in my office the other day. They were CAT scanned at an outside facility and they're 2 months out and they can barely stand. This patient, not so much of a low energy injury, but they are geriatric, more of a geriatric trauma patient. Fell off a ladder hanging Christmas lights. The only real medical condition here is obesity, and they were a little hypotensive on arrival. So CT scan shows that they have a right-sided sacroiliac injury. They're wide in the front, and it's amazing to me and there was even a paper on this, but when you put a patient like this, when they come in with an X-ray and the symphysis is widened like this on the AP pelvis, with the binder off, by the way, I harass my ER and trauma team because we continually get X-rays with the binder on, and they look like they have a normal pelvis. So I've really made it a point to harass everybody downstairs, tell them you got to get the binder off. Just give me an AP pelvis with the binder off, because that will tell me a lot of times with an injury like this more than a CAT scan. To put somebody in a CAT scan. What's that?
Even if they're hypotensive?
Yeah, even if they're hypotensive, once they're kind of resuscitated, you just have, the person on either side of the patient slide the film underneath them with the plate, undo the binder, get an X-ray, put the binder back on. pretty quick. I mean, it takes like, when everything works properly, about 10 seconds.
I think you just said the most important thing, that once they've been resuscitated, if they're still hypertensive, I would not recommend taking the.
Yeah, no, they don't even call me until the patient's usually been
Okay, got it.
resuscitated half the time. But yeah, you're not going to do that while they're actively pumping, colloid and crystalloid into the patient. But yeah, once they're resuscitated, because when you put them in the CT gantry, it'll actually close you down about 15 degrees, and you get a much less impressive posterior injury than you do with a binder off AP. So for me, that's absolutely critical. Because you see here how much it closes down the symphysis when you just put them in the gantry. So the patient was brought to the operating room. External fixator was put on, and then it's like, let this guy sit on ice, and we'll bring him back later for more definitive fixation.
Nick, can I ask you a question real quick?
Yeah.
When you, so we have this debate all the time in these APC 3, 2.8, 2.5, whatever you want to call it, right? You're not entirely sure how many posterior ligaments are disrupted, and the value of an anterior external fixator, which with the concern of gapping open the posterior ring, versus a circumferential binder for 24 hours and then definitive fixation. And I get kind of asked regularly to come in acutely to put on an anterior binder or an anterior fixator. And there are times when I try to push back because I think it will actually make things worse. How do you make that decision, or anybody on the panel? What are you looking at posteriorly to try to help you with that decision? Because I don't think it's something I do very well.
Yeah, I kind of struggle with that, even if they do have vertical instability, which for me is something that you need more than an anterior external fixator, because that can gap you open a little bit in the back if your posterior ligaments are disrupted. So you put on an X-fix and then put them in distal femoral skeletal traction. You put them in an X-fix and a resuscitation screw. And for me, if you're already putting in a resuscitation screw, take another 5-10 minutes and just fire in 2 transiliac transacral screws. Dr. Williams, how do you proceed when you have something like that?
I struggle with this, with the same thing. I think once you're in the OR and you have a joystick in and you can manipulate things, you can make a diagnosis or better understand the injury. But when you're called with the imaging you just showed, I don't have a conclusive way or a helpful strategy to decide whether it's a B or a partial injury or a C or a complete injury. For this particular patient, though, I think a sheet would have been my first step, and then get a repeat X-ray and see how he changes or doesn't. And if the front of his pelvic ring closes down and really the volume decreases, which is what we're after, I would do that rather than an X-fix. But if you can tell it's a C-type injury right up front, then definitely not an anterior X-fix. I think a sheet for that patient and anterior X-fix isn't going to be that helpful because, like you said, it's going to gap open the back.
Matt, how are they ever convincing you to? I mean, if they told me you need to come in and put an X-fix on, I would say why. Oh well, he's unstable. A binder is going to decrease his pelvic volume as much, if not more, than the X-fix, especially in a fat person. And the only reason I would put a frame on is if he was going for open pelvic back, which happens here.
No, I agree completely. I'm soft and I come in when I'm called, but other than that, it's a lot easier for me to say no when I'm doing it face to face and in person than over the phone, because then but I completely agree. I think the role of a binder for the first 24 hours shouldn't be understated, right? And that can be done anywhere in any emergency department by anybody. And the rule of thumb that I give to our general surgeons, which may or may not be accurate, is you should be able to do your X-lap with the binder on. That means it's in the right place, it's low enough. And you don't need me to come in to put a frame on so you can do an X-lap, right? So I don't know, Dan. I just think it's I think it's really important to hit the point that a binder works, and it's usually the best answer. But there, again, in this case, there are indications for a sport frame or an anterior frame. So,
Dr. Craig, how unstable was this patient? Did he have any kind of X-lap or did he go to VIR or anything?
It was a while ago, I recall. He did not have an X-lap I believe he went to IR. We put a frame on him mostly for resuscitation, but also timing. It was one of those quasi, people hate to hear it, but cleared for an X-fix, but not for an open procedure sort of thing. Let's put a frame on him. He went to the unit for prolonged resuscitation. My concern mostly was the length of time until I could get to him for an open procedure to fix the front. That's why I want to put the frame on. Also allowing him, the soft tissues with having a sheet or a binder on for too long. But now he's got some stability if he's having multiple procedures and being moved around. So it bought us the time to get him resuscitated and proceed to the OR when he was ready.
Yeah, and I think that's what's critical to understand with the geriatric patients is they can go downhill overnight, unlike a young trauma patient, which, for something like this in a 24-year-old from a car accident, put them in a sheet, they can sit in a sheet and, they're a little more predictable as a trauma patient than someone in their 80s. So I think the X-fix here is very appropriate because this guy could turn overnight. He can have an MI, he can throw a clot. I mean, he can have a lot of problems in the next, 48 to 72 hours. And they just don't have the reserves to recover from certain things like a younger trauma patient. So how long was it before you were able to get him back to the operating room?
That was about 5 or 6 days.
Okay. So you brought him back. You got 2 nice transiliac transacral screws in the back, fixation in the front. Looks great.
Well, hold on. It's not as nice as you think. There's one, his first name was Roman. Roman since passed away. This is a case from a long time ago. If we're going to talk about stuff, in mea culpa, I broached the lateral wall with my screws posteriorly, and he's huge. You can kind of see my suture line, staple line. I had to get the Scout CT scan, my postoperative CT scan, because he's an immense guy with this huge belly, as you can see. Anyhow, please proceed.
When you say you broached, what do you mean? You mean you put the screws with the washer through the lateral wall?
Well, yeah, his bone was poor, so we went through the lateral wall with the washers posteriorly. You can kind of infer that with that X-ray.
That happens. That can happen with these elderly patients. I don't fully see my screws unless I'm looking at it on X-ray with a like an iliac or like an obturator inlet view. So I'm kind of looking at that outer table as I screw them down because I've breached the lateral cortex several times in the past.
Yeah, one
so
trick is if you do breach it, I think a lot of people on this are probably not putting in SI screws, but if you do breach it with the first screw, a great trick is you take a 3-hole 4-5 recon plate and you put the screw through the center hole. You won't breach the lateral cortex with that as a washer.
That is
Requires a little bit of incision.
Would anybody have gone transiliac transsacral here?
So I would have put, I think the reduction looks great. I would have put one partially threaded out the other iliac wing, and then I would have put probably a fully threaded for the comment that was made before. I think the fixation is not reliable. I mean, definitely one partial though to close it down.
I think 2 fully threaded for me all the way across. For somebody that's this large and this osteoporotic, I want as much fixation as possible. But not, that doesn't mean I do that 100% of the time. If somebody's younger or if their bone quality is better, I think you can get away with less. But for somebody that's this large and this osteoporotic, more.
Yeah, one thing you can do actually is, I've done this, put in a partially threaded, close it down, put in a fully threaded, take out the first partially threaded and exchange it for an 8-0 fully threaded. It's a pain in the ass, but.
Yeah, I agree. I've kind of progressed to kind of like what you just spoke on, Joel, where you just maximum fixation. Something like this, I tried to fill up as many of those posterior corridors with as many threads as possible. And Matt, post-op, what was his weight bearing restrictions, if any?
We call it toe touch on the right, weight bears tolerated on the left.
Okay. And then this was still within the first 2 weeks, because you see the staples. And with really poor bone, and this guy looks like he's enormous. This can happen.
So I've Eric Kubiak has talked about this a bunch, and I've only done it once. But if you're plating the front like this, and they have really crap bone, This is a case where you can either leave the anterior frame on or convert it to an infix. So double your anterior fixation. And I've done it once here in a really obese patient.
Yeah, I've had a couple where I've actually done fixation similar to this, where you plate the front, screws in the back, and even still then leave on the external fixator just to allow weight bearing, especially in somebody with really poor bone quality or if they're enormous. But I've only learned that through trial and tribulation.
The anterior frame in him is challenging because of his size, but
Yeah.
Knowing what I know, doubling things in the front is a good idea. But when people are making comments about fixation in the back, whether you went longer screws here, double, fully threaded, still didn't stop the fact that he's got osteoporotic lateral wall, and it's the ilium that gave up here, not the sacrum. So if I increased my fixation in the sacrum, I would have landed in the same place. The lateral wall, the ilium gave up on me, or I crushed it. Just something to think about. Increasing our fixation in the sacrum doesn't improve the lateral fixation.
Well, I really like what you did here. This is very good fixation. I like the double plate in the front.
So if one is good, two is better. If he failed, two screws in the back, so I had to open everything up. I had the washers themselves from the SI fixation were in the SI joint, so the screws came out without a problem. But the washers had to be retrieved from inside the SI joint, and then attempt to get a 90-degree fixation of the SI joint posteriorly, and then a double plate fixation of the pubic symphysis.
You consider leaving the SI screws in? And I only say that because I have, and I'll tell you, when you leave the SI screws in, the screws that you have in the sacrum, you can actually lock into the screws for added fixation. It's just, I don't think you have to take them out. I mean, unless they bother you looking at them.
They bothered me looking at them, I suppose, but then I was unsure if it was going to block my reduction, so I wanted them out.
Yeah. Does anybody here ever take out the pubic symphysis and get bone-to-bone fixation, increase the strength of the construct, or are you leaving in the symphyseal cartilage?
I don't. I know Paul Tornetta talks about that and his success with doing it. I don't see the point.
They did it the other day for the first time, and it was only because the symphyseal disc and cartilage was in like 1,000 pieces, and just sucked it out with a yank hour. But no, it's not part of my routine practice.
But were you trying to fuse it, or you just took out the beat up cartilage?
Took it out so that I could better assess the reduction. Whether it fuses or not, don't know, don't care. But
so I've asked Paul this, and the problem I have is that if most people, I know it's not a shit ton of cartilage, but if you bring bone to bone, you've now reduced their anterior pelvis. So then, as long as you're willing to accept, rotation posteriorly, certainly if you fix the back first and then you over-reduce the front, you're already applying stress to your posterior fixation. So I don't know. Paul and I fight about this all the time. I'm like, everything else we reduce to the anatomic position, not beyond it. So I guess I don't understand why that would give you more stability, but maybe I just don't get it.
Yeah, I don't think I really understand.
No, I don't claim to understand this better than anybody, especially Paul Tornetta. But my thought was I could get big bodies as opposed to leaving a gap where the symphyseal cartilage used to be. But I'm not don't want you to walk away thinking that I've been doing this routinely. It was just one-off thing that happened the other day that I thought of when you mentioned that.
Yeah.
Dan, I'd agree. I mean, it's the idea of why we jump. It's fusion to be a reconstructive procedure. I don't fuse on my ankle fractures because maybe they'll get arthritis.
Yeah.
They might be unstable. I would just fix the fracture, and if there's a problem down the road, deal with it.
Yes.
The other trick you can use in these osteoporotic patients, and I learned this when I was in Utah, and I took care of a lot of Bronco riders because they all came in with AP2s, and you'd fix them, and these guys were back on a horse 2 weeks later. I mean, There was no way you keep them off. So all of them, they would all loosen their screws in the front. So I would put on a 6-hole plate with 3 screws. And after the plate was in, I would bring a 5mm, suture, a 5mm suture tape through 2 drill holes, usually the same drill holes that I use for my reduction clamp. You bring them front to back and you tie it down, and it's, it's not rigid fixation, it's semi-floating fixation. But when they loosened their screws, they would gap maybe 1 centimeter, not back to 4 centimeters. So I've done that supplemental fixation in osteoporotic patients, even though I don't think they're going to get on a horse. I don't know whether it's really beneficial, but can't hurt.
Were your Bronco riders symptomatic? We see the radiographic widening, but were they symptomatic? Or they just kept riding and it didn't bother them?
No. I mean, these are guys that would come in with a fracture dislocation of their hip, and they get into the pickup truck. I'm not kidding, and they would friggin' drive themselves 8 hours with their hip dislocated. I mean, these guys would never complain about anything. It's just a little freaky, but yeah, none of them complained. They never had. I said I had instability, and we need to go back and do fusion. So
That's very interesting. That's a good point. I think a lot of times you get loosening in the front for these elderly patients. For me, it's just I want maximum fixation. So I have had a couple where I've taken the symphysis out, but only in these elderly osteoporotic patients where your screws don't get great bite, and we're not putting locking screws in there. So for me, I've done it twice, just like Joel said, just because you felt like you needed a little bit of something more. But I think the double plate here is great, and I think this is like a 5-year on X-ray, and looks like you healed up real nice.
Well, that guy's got staples. Do you have one more shot or no?
yeah, wow.
There you go.
Yeah, 5 years out.
So this guy also, people talk about the transformational patient, the fact that I failed the first time and then he fell in the hospital. So it's, delirium management, all this other kind of stuff to deal with an elderly patient. But then he kept showing up around every Christmas. So just as an aside story, his sons lived out of town. He eventually moved into an assisted living facility. His sons would come into town, pick up dad, go take him to see Dr. Craig for a visit, and then go out to lunch. It was like their little Christmas holiday celebration. So he kept showing up every year. I didn't want him to. I didn't ask him to, but their sons were so grateful and they're happy they had dad. So I had this 5-year follow-up, and I just remember the guy. So it helps for talks. And then we're just talking about loosening. Yeah, one of my plates loosened up in the front, but he didn't really widen, and has no symptoms. They're all very happy.
Yeah, that looks great. That looks great. So in the sake of time, I have a bunch of elderly acetabulum fractures. I'm going to rip through a couple of these, and then we can all talk about it later, because there's a lot of information to cover. But just a couple of points I want to get through is, we can proceed with non-op versus percutaneous fixation versus ORAF versus total hip, or a combination of perc fix and total hip, or ORAF and total hip. And acetabular fractures in the elderly can be a pretty slippery slope. You really have to balance their comorbidities, their expectations, and then the salvageability of the joint, which is really where that algorithm proposed by Carol, comes into play. But this patient, 80-year-old, fell from standing while trying to change a light bulb. A lot of medical conditions, but they're also pretty active. I mean, he walked 1 to 3 miles a day with his wife, depending on how he felt. So a really active guy, history of prostate cancer, as you can see. And he has a minimally displaced transtectal transverse. This is a CT scan. So you could probably get away with doing nothing. But again, the guy is super active. So I brought him back and just kind of did, minimal fixation, just percutaneous fixation. I got a supraacetabular screw, and then just a retrograde posterior column and retrograde anterior column screw, all through small incisions. I didn't need to make a lateral window or anything. I didn't even bother putting on a collinear clamp, just percutaneous fixation because he was so non-displaced. And this is him 6 months out. He was doing great, really happy. Would anybody on the panel have done anything more aggressive or non-op?
I would never have touched this guy.
Yeah, I think there's a lot of people that would say that too. One of my mentors, I kind of showed him the case, and he was like, "Yeah, I would do nothing."
In
But the
3 weeks,
patient,
he's going to be, in 3 or 4 weeks, this guy's going to be asking if he can start walking on this and ride his bicycle. I just, if it was a little displaced and you were going to suck it in, then I would, give you that one. But I don't think,
yeah,
you have great looking x-ray with great screws, but I don't think it's made him any better.
yeah, that was kind of my initial thought. But the guy was super uncomfortable, and he couldn't even get from bed to a chair. So he was really uncomfortable. And with all those comorbidities, I didn't want him sitting in bed for really any period of time. So I was like, look, we could bring you back. It's going to take about less than an hour. You're going to have very little blood loss, firing a bunch of screws, and you should feel better right away. And he was great. I mean, I can't remember exactly when he was discharged, but he was discharged to home within 2 or 3 days, and he was really happy.
Why not use fully threaded screws if you're not trying to reduce it?
This was years ago. I have gone to almost using exclusively fully threaded screws for acetabulums and pelvises. When the screws are that long, you almost cannulate the near corridor with all the threads anyway. So I believe that you can still get compression with a fully threaded screw in the back of the pelvis or on an anterior column. How about Joel? What do you think? You use fully threaded screws or partially threaded?
Oh, full thread for the most part. If I'm doing something where I'm intending to compress a lot. The other day I had a sacrum fracture, an LC3, and the externally rotated side was gapped, and I used a partially threaded screw first, and I exchanged it, as somebody said, for a fully threaded screw at the end of the case. But for the most part, fully threaded right out of the gate. And I believe, I can't remember what journal it's in, but John Eastman has a publication that shows for posterior pelvic ring fractures, fully threaded screws do compress.
Yeah.
Anything will compress if you turn it hard enough. I mean, come on.
Yeah. I think the corridors are long enough and the screws are long enough and big enough that you can kind of get it as much compression as you want.
I think it depends on the bone quality.
5 minutes.
You have a 30-year-old and you put a fully threaded 8/0 screw in S1. I don't think you're going to compress a zone 2 sacral fracture. I don't think you are. I think that the lateral bone is as good as the lateral bone on the other side. You're going to reach an end where you either start stripping or you bring the head through the iliac ring. Derek made a point before, you can compress these by technique, not just by threads. And that's actually a great thing to remember, because even in a young person, if you over drill the near, the SI joint, then you can compress with a fully threaded. So it's kind of a balance of both worlds.
Yeah. Dr. Gardner, would you have done anything with this patient or just left him?
Yeah, I tend to treat these, especially with secondary congruence, however you want to define that. I tend to treat these very similar to the way I treat pelvic rings based on their ability to get out and mobilize. I do follow these a little bit closer because displacement to me does make a difference. So if, unable to mobilize, I agree with Dan, this would heal fine. It would probably heal. It would heal in the exact same position that it was fractured in, but if it was for pain control purposes, then I would do the same thing.
Yeah.
And then Nick, what was his activity level, or what were your rehab instructions post-op? What was his weight bearing?
As tolerated. If I'm fixing an elderly pelvis or an acetabulum, I almost always tell them weight bearing is tolerated. And most of these people aren't going to go do anything ridiculous. If it's somebody who's, rides horses or something to that effect, I will try to tone them down a little bit with their activity, but I let them all weight bear as tolerated.
Yeah, I could go either way with this case. If you're going to treat him non-op, he's probably going to limit his weight bearing. His activity won't be great because he's going to need pain. But if you fix it, you got to be aggressive with rehab. You're going to be aggressive surgically, be aggressive with post-op rehab.
Yeah, I agree. The whole point for me is to avoid complications of immobility. So it's like, I'm bringing you to the operating room. I want you to move around.
So I'm going to disagree with you guys. To me, this is an intra-articular injury, and my protected weight bearing is not because I'm worried about his construct. I'm protecting his weight bearing because I think the studies are good that early weight bearing with intra-articular injuries, you have significantly more chondrolysis and apoptosis of the cells. So I don't know whether it's going to make a difference, but I'm going to have him protected just so I don't beat the crap out of the cartilage that already had a major impact injury. You know, when I fix a stable plateau that's just a lateral split in a young person, I don't let them weight bear on it. It's not because I'm worried about my fixation. It's because I'm worried about the condyle surface. But maybe I'm just weird.
No,
That's-
I agree.
that's-
In a younger patient, I would do foot flat weight bearing for 1 or 2 months. But in this guy, you know, it's like I kind of wanted him to get up and moving. And most people, like Matt said, most people will self-limit anyway, and essentially do about foot flat for 4 to 6 weeks, and then start the weight bear as tolerated. I've just found that if I limit them, then physical therapy does nothing with these people, which also kind of comes into some of my decision making. I'm going to flip through this one because I want to get to this case here,
Womp womp.
because I think everybody would have done something different. 80-year-old male fell off a second step onto his right hip. Road bikes daily. This guy puts tons of miles on his bike, but he has some significant medical conditions as listed, a lot of heart problems, and he has this, you know, transtectal transverse with a lot of impaction. These are his x-rays or his CT scan. So I brought him back, did everything through an anterior intrapelvic approach, got his dome, you know, reconstructed, or at least what I thought was some K-wires, put on a suprapectineal quadrilateral plate, had a lot of good fixation, was pretty satisfied with it. Left a couple of fully threaded K-wires behind the impacted segment. But in an 80-year-old, you know, Dr. Garner, would you have done a total hip on this guy, or would you have done fixation or fixation with total hip?
So I would advocate for a total hip, and not because I don't think your surgery was, I mean, that was clearly well done, and I think as well done as any of us could do. The problem is, you know, dome or anterior column impaction in an osteoporotic patient is miserable to deal with, and I don't think we can control it with implants. You know, you look at the European data, that this is 100% conversion or 100% risk of severe post-traumatic arthritis, right?
Yeah.
This is, you know, probably a low, it looks like a transverse, but it's probably really a low anterior column, posterior hemitransverse with impaction. I don't think we have a good way of dealing with this problem. It used to be called a central hip dislocation. The quadrilateral plate's usually involved. These migrate medially and superiorly, and it happens really quickly. And I'm not good enough to fix it as well as you did. I would advocate for similar fixation or not, depending on the pattern, with an acute total hip. I'm sure others would disagree with that, but I think it's the best option.
I think you're on that. Sometimes you don't need to do an acute total hip, but you tell them they're going to get an acute total hip in 3 months. My only comment is I would avoid, you have a lot of supraacetabular screws there, and I'm not a total joint surgeon, but my total joint surgeon would be cursing me. I would try to keep some of those a little farther away, anticipating a reamer going in there and leaving enough room. But
Yeah, that's kind of why I picked this case, because I think I went about this more as if the patient was 40 instead of 80. You know, I got lucky. The guy did well. He had a little bit of hip discomfort, but he got back on his bike. But I think here, although I was able to do everything through a single approach, it didn't take too long. It was like 3 to 4 hours, not a lot of blood loss. I use Cell Saver all the time on everybody so they can get back some of their loss. But I don't think I was realistic with my expectations as far as preserving the joint here. I think it would have been easier for him during, the following months, like 6 through 12 of his first year, had he had a total hip. Joel, what are your thoughts on this?
Yeah, I think for this guy and his activity level, just based on the central impaction or the dome impaction, acute total hip. And if I'm doing that, I would fix it as you did and buttress it with a suprapectineal and likely quadrilateral surface adjunct like you did, depending on the fracture pattern, and then also total hip from the front. The screws close to the joint, obviously, if you're replacing it aren't critical. But I think if you're doing a stage plan from the get-go, we're going to fix it, see how it does, and then do a total hip later on for whatever reasons, then yeah, avoid screws, the rafting screws close to the joint to help with the subsequent reaming. But if you're going to fix it, and there's dome impaction, then I think you need screws close to the joint to raft those fragments. So I think it's the decision you have to make before the surgery and have the discussion with the patient and total joint surgeon if that's part of the plan up front.
Yeah,
I think that reduction is awesome. Yeah, I'm with you. Like I don't think I could do as good a job reconstructing his joint, but just based on that fracture pattern and that guy's bone quality, I think everybody suspects where it's going to head.
Yeah. So I think those are key points. I think I just wasn't realistic as far as the joint goes, but we're at 9:30, so that's all the time we have. Thank you to the panelists. I think we had a lot of really good discussion on some pretty controversial topics, and I hope everybody got something out of this. Low energy fractures in these geriatric patients are not the same as high energy. CT scan your pelvises and then individualize your treatment plans so that you can mobilize these patients in the safest manner and hopefully have a good outcome. So thanks to everybody.
Thanks.
All right.
Yep.
Thank you, Nick. Great job, Nick. Thank you, everybody.
Thanks, Nick, and thanks to the whole panel.